Okay, so basically the today's topic is trauma and burn. So we'll start with trauma first. So as you know, this is all case-based scenarios. So let me first start with a simple case. So basically, this all these cases, it's the cases are taken from different structured courses program. So this is simple case like a motor vehicle accident, 53-year-old male. AC has a frontal impact. So the questions may arise like how do you manage this patient? Okay. So the simple case, 53-year-old female, frontal impact. So he came to the ER and you, as a ICU physician, the person who is in the ER. So how you are going to manage this patient? So this is a particularly the case of a trauma patient. So there are a lot of history which may be given particularly for a trauma patient like patients of polytrauma. So polytrauma means the trauma involving more than two organ systems. So either it is a head injury with abdominal injury or some head injury with some kind of the lower limb or pelvic injury or something kind of chest injury with abdominal injury. So more than two organ system or more compartments are involved. This is called a polytrauma. So the polytrauma patients may be something they may be stable or they may be unstable. So the first thing, any patient who comes to the ER, polytrauma or any other patient, so the general principles like A, B, C, D, and E, particularly in a trauma patient, we have to follow that A, B, C, D algorithm. So A is airway control with cervical spine stabilization. B is breathing with ventilation. C is circulation with hemorrhage control. And D is disability with deformity assessment. And E is environmental control with exposure to prevent hypothermia. So basically, this patient, when he came to the ER, so let's see how the ABCD basically goes on. So basically, if you see this patient, so the airway is patent because the patient is awake. The patient is like conscious. He is able to tell his name. So the airway is patent. So if you see on examination of the breathing, there is a decreased chest movement on the right side. The saturation is low. Patient is tachypneic, and there is bilateral surgical emphysema is present. The circulation assessment shows that there is a good capillary refill time. The heart rate is 105 per minute, suggestive of tachycardia. The blood pressure is okay, little on the lower side with some normal mean arterial pressure and good capillary refill. That's suggestive of good perfusion. So we are not immediately rushing to give her a lot of fluids. In fact, now we have to look after his breathing because the breathing area is an issue here. You see that the chest movements are decreased on the right side. Patient is tachypneic and desaturating. So on the neurological examination, the GCS is 8 and the pupils are 3 reactive. So this is a scenario, and so going ahead further. So basically, once we see, like for example, this patient. So what could be the possible cause of his decreased breathing? So the first thing is before securing the breathing, the most important thing is to secure the airway because this patient the GCS is low, so it is less than 8. Any trauma patient where the GCS is less than 8, so this patient needs to be intubated, and after the intubation, so this patient normally what we follow the intubation practice in trauma patient is rapid sequence intubation RSI, which is nowadays modified and it is called the drug assisted intubation. So the most important part of any trauma patient, you have to take care of the cervical spine unless until proven otherwise. You have to absolutely stabilize the cervical spine. If you suspect there is a cervical spine injury, there are lot of criteria, particularly the Nexus criteria and the Canadian cervical spine rule, which actually tells us that whether this patient's cervical spine need evaluation or not. particularly both the criteria, most of the things are same. So any patient with severe neurological disability, any patients with trauma directly on the spine, history of fall for more than 5 feet, or there is a ejection from a motor vehicle or a vehicle which is almost speeding at a rate of more than 100 kilometer per hour, and there is associated severe fracture of the or severe injury to the brain, traumatic brain injury. All those patients, they are suspected to having cervical spine injury as per the Canadian cervical spine rule and the nexus criteria. So in those patients, the cervical spine has to be stabilized, and this is called the manual inline stabilization of the cervical spine. So the manual inline stabilization has to be done by two operators. So one person in the head end and the other person who is actually holding the spine like this, and the person who is going to intubate. So he has to first mask ventilate gently and for a brief period, and this is called the rapid sequence intubation. One important, very important point is only the jaw thrust is advisable. The the chin lift and neck tilt, actually it is not recommended in case of cervical spine injury. So as per the protocol, this patient has intubated with the cervical spine protocol, taking care of the cervical spine, like keeping the cervical spine in the neutral positions, intubation during the neutral positions, and manual inline stabilization of the neck with rapid sequence intubation. Okay. And after intubation, this fellow was put on ventilator. Okay. And now, if you go to the breathing areas, we find that there is definitely a reduced air entry, particularly suggestive of something like your traumatic pneumothorax. So the pneumothorax particularly is very common. That is called tension pneumothorax. So if there is a breathing problem like desaturation along with decreased air entry, high peak pressure, and one suspect that there is a possibility of pneumothorax. So if the intensivist is expertise in identifying the pneumothorax by point of care ultrasound, so he has to use here the point of care ultrasound. There are subtle signs, particularly which suggestive of this is a pneumothorax, like absence of, you can say something called as the absence of lung sliding, which is very important, or presence of lung point, and there is a something called as the barcode signs. So normally once we do a point of care ultrasound, there are lung pulse and there are lung slides which is normally present. But in case of localized pneumothorax, there is an absence of all these lung pulse and absence of the lung sliding. So the area remains fixed. And if we put an M mode ultrasonography, we found there are very nice barcoding signs, and that is particularly suggestive of pneumothorax. So this is particularly the tension traumatic pneumothorax is a clinical diagnosis. One don't has to wait for a X-ray or wait for some point of care ultrasound. It can be sometimes diagnosed even clinically by auscultation and you can say the percussion also. And immediately with a high suspicion of hemodynamic instability, the initially to do a needle decompression. So right now the recommended part is doing a needle decompression in the fifth intercostal space anterior to the mid-axillary line, which is before it was practiced to be in the second intercostal space, but now it has been changed. The practice has been changed to fifth intercostal space. So of course this patient has tension pneumothorax, he has subcutaneous emphysema. So chest drain has inserted after the needle thoracotomy, needle decompression, and particularly in view of bilateral pneumothorax, the bilateral ICD has been inserted. Already he has been intubated and the fluid infusion is going on. So the blood pressure has picked up. Now what is the next management? Okay, so now the hemodynamic point of view, this patient has improved, but there is a bilateral chest drain and there is already this patient is on ventilator. So his GCS is low. So now after stabilization, so of the ABC, now we have to assess the disability and we have to immediately shift the patient to CT scan, because since the GCS is low, we need to find out why the GCS is low. And these are the typical history given by this patient. So the speed of the vehicle is around 40 km per hour. That is the passenger which is with this particular subject or this particular person is, and the passenger which is there had died at the scene. and the passenger is not wearing the seat belt. So this is particularly very high, is a history, typical history, which is as per the nexus criteria and Canadian cervical spine rule. We definitely have to suspect the cervical spine injury, and obviously this is the GCS is low. We are now subjecting him to the CT scan, okay, to know whether there is an underlying any bleed or any kind of fracture or any kind of like diffuse axonal injury or massive cerebral edema, which has led to the falling down of the GCS. And of course, as a protocol, we have to do the CT cervical spine because all the history that's suggestive of that patient has a very high risk of cervical spine injury. So the neck is immobilized, and now after stabilization, so quickly there has to be a secondary survey. So the primary survey, secondary survey, and tertiary survey. The primary survey of the trauma aims at the very high risk life-threatening injuries, particularly the your brain injury, the traumatic brain injuries, and the injuries involving all the vascular structures and the something called as the airway injury. So these are the immediately the primary survey. So the primary survey, after the primary survey, the ABCDE is over. The secondary survey is actually focused at finding out the subtle injuries which is actually missed in the primary survey. And this is basically a survey which is done from head to toe. So the secondary survey of this patient shows there is a bruising over the left chest, lower chest, the abdomen is soft, and the swollen left thigh is there. So there is high possibility of limb injuries is there, and particularly the bruising over the lower chest suggestive of there might be underlying abdominal injury, but the abdomen is soft to palpation. So if you have an ultrasound, so particularly this will help to do a EFAST, something called as the focused assessed sonography of trauma, which is rapid, and it is one of the very important screening method to know the underlying visceral injuries. So if you see the pupils are dilated, and you can see that this patient GCS is low, and this is the X-ray of the same patient. So we can see there bilateral ICDs are there, and there is a subcutaneous emphysema is there, and so if you see the margin of both the ICDs, they are very close to each other. So particularly the ICDs have gone too deep inside. So we need to remove the ICD slightly, okay, or manipulate the reposition the ICD, and then again check the X-rays. And this is the endotracheal tube. So the endotracheal tube is in the proper position, and you can see the extensive subcutaneous emphysema for this patient.